So as Chief Baldwin mentioned, my name is Kristen Hall. I am a emergency nurse. My full-time job is up at the U in the emergency department. And my background is EMS. I went to paramedic school a few years ago, and I've been working kind of emergency services since. I started in forensics 3 years ago, and since then, this has become my passion, and it's really kind of been building and really taking hold here, which is nice. We went as a multidisciplinary team to San Diego in 2016 to meet with really the kind of founders and the ones that are pushing out this strangulation movement across the nation. And there's been a lot of research studies that contribute to this topic from San Diego. So it was very nice to hear from the researchers themselves and kind of learn why this is such a big deal. Since then, we brought it back, and it's been kind of been a process to get it to kind of take hold here. But we're really excited that we're starting to move forward. We're starting to change protocols. And we'll talk a little bit about what that looks like later on. But really, we want to kind of get the education out there, make sure they're all on the same page and understand kind of where each other are coming from when we talk about working as a multidisciplinary team. So as Chief Baldwin may have, or as he mentioned, this may not be something that is new to you guys. I'm not going to teach you something that's totally outside of your wheelhouse, but hopefully that we can kind of put it together so that it reframes your mind, and when you go on these calls that you can kind of have a little bit more tools and understanding in your back pocket on how these calls fit together and why it's such a big deal. We're going to start off by looking at a video. This is a few different victims kind of telling their stories in their words. I won't make you listen to the whole thing, but it kind of gets us started on the right mindset and understands how they describe things in their own words.
I saw stars and I passed out. And when I came to, he's on top of me, banging my head up against the kitchen floor, and he's strangling me.
I was trying to get away, and he grabbed me, spun me around, started to choke me, and brought me down to the ground. And at the same time he was trying to choke me, he was trying to hit my head on one of the rocks.
He woke up and immediately started choking me and put me up against the wall, and I fell and I urinated on myself, and then right after I hit him, he let go from choking me, and he started repeatedly punching me to the floor.
He had threatened me that if I was to call the police, that I would be the one going to jail. Other times he would threaten my life.
He choked me millions of times. We have a butcher knife, and he put it up to my neck right here and told me not to breathe.
Well, for many years, we didn't realize what strangulation was. We would see it over and over in police reports. We would hear victims say over and over, choking, choking, choking. He grabbed me, he choked me. Didn't mean anything to us. And we certainly didn't understand how lethal it was. But as we started to get into it and started to deal with the medical experts and put them on a witness stand and started hearing the actual accounting of what was going on, and then had research to back it up, we found out that choking wasn't down here. Choking was right here, and a homicide was right here. And suddenly, choking is strangulation, and now we realize if you're at strangulation, you're at death. You're right on the edge of murder. If you're going to do strangulation cases, you should be foaming at the mouth in a courtroom when it comes to this crime. You should be so outraged and so upset and so angry about how this serious, felonious criminal has gotten away with attempted murder over and over, perhaps, in that relationship. Because if you're not that way, nobody else will be.
That's Casey Gwynn. He's the CEO of Alliance for Hope. They're the organization that kind of put forth the 4-day training down in San Diego. He's obviously very passionate about this subject. He's a survivor from childhood abuse and is a prosecutor down in San Diego, and he's really kind of understood what this means for us and has helped us kind of spread the word throughout the nation. So why is this such a big deal? Why do we even care? Why are we here? Strangulation is scary because of many different factors, but we're learning that it's one of the best predictors of future homicide and one of the most lethal forms of domestic violence. It's a lethal force that can quickly result in death. One episode of strangulation puts that victim at 7.5 times more likely to be killed by that abuser. 43 female victims of domestic violence homicide and 45% of female victims of attempted murder had been strangled in the past year leading up to their attempted homicide or homicide. And then we're learning that most strangulation victims do not seek treatment. And that's kind of why we're here, why we're spreading the movement with you guys, is that we're hoping that by getting EMS involved that we can kind of increase those rates and that we can encourage them to seek the medical attention that they need. We're learning that, as Claire mentioned, that women are 10 times more likely to be victims of strangulation than men. It is not a gender-specific crime, but it's pretty close. It's a power and control maneuver. It often isn't to prove that, or it isn't to kill them, to prove that they can kill them. Most strangulation incidents also involve blunt force trauma. Think about them with their head being hit against a hard surface, or that they've been pummeled up until this point. It's an escalating type of crime. So they aren't living happily one day and the next day he's choking her out. It's been a building process. Most women who reported a strangulation admit that it had happened before. So this is huge for us. When you're finally finding that indicator that strangulation is occurring, this isn't the first time that she's been choked out. This has been going on, and we're just now finding out. We're now asking the right types of questions and really understanding what's going on here. 41% of strangulations are witnessed by children. This is a terrifying fact because this is our future perpetrator. He's seeing this cycle, and that's what's he's gonna kind of mimic in his older life if we don't intervene. So, if for no other reason, this is why we need to start getting these victims some help. 70 to 80% of intimate partner homicides, the man physically abused the woman before the murder. That's probably not shocking. As we talked about, it's an escalating type crime. They don't go from happy to murder in the next sentence. We talked a little bit about this. Most abusers do not strangle to kill. They strangle to prove that they can kill. When the victim is strangled, this is the step right before he kills her. This is our warning to say this is where we need to intervene. Otherwise, next time we go on this call, she's going to be dead. This is a local statistic. 49.4% of clients who sought services last year at the Family Justice Center answered yes to the question, have you been choked or strangled in the past year? This is higher than the national average. The national average is about 47%. So our rates are much higher than the national average. A single near-death experience of strangulation or threat of it may cause so much fear that the victim may be trapped in that pattern of control. Again, it's not to kill them, it's to prove that they can kill them. The victims often downplay this and say, you know what, it's okay, I'm okay now, I can breathe now, I don't have any marks on me, I'm fine. But in reality, this is a very lethal form of domestic violence. This is something that we should be very concerned about, and we'll talk about why that is. We're also learning that the men who strangle are the men that kill officers and first responders. We found that across the nation, 14% of officers killed in the line of duty were responding to a domestic violence incident. Idaho did a study looking at their last 10 officer-involved shootings, and they wanted to look at whether or not the perpetrator had a criminal record of domestic violence and whether or not there was a public record of non-fatal strangulation. And they found out that 80% of the suspects had a prior history of domestic violence. 30% of them had a prior history of strangling their partner. California did a study, and their numbers were closer to 50%. And these are the strangulation incidences that we know about. So we know that they don't often report, so this number is actually probably a lot higher. So we're learning that those that will strangle their partners will not hesitate to kill those that come to help them. We'll look a little bit about what happens with trauma in the brain, and then we'll get into strangulation-specific things. Talk about kind of 3 structures of the brain that are involved with the traumatic incident. The prefrontal cortex is right up front here. It's responsible for all of your rational thinking, how to get to and from places, reading, stuff like that, any types of learning. The amygdala is your survival brain. It's right in the middle at the base of your brain. It is responsible for one thing, and that's keeping you alive. So it's the alarm center, and it makes all the decisions about keeping us alive. The hippocampus is responsible for memory storage. It is very oxygen dependent. If it's not getting the oxygen it wants, our brain is not going to make memories like it should. Trauma is trauma is trauma. Whether or not it's a car accident on your way to work, being held at gunpoint, a bad day at the office for law enforcement or first responders, or being kidnapped and assaulted. Our brain views trauma as the same. It doesn't pick and choose, or we don't get to pick and choose what we deem as traumatic. Our brain gets to decide what we deem as traumatic. So this is why officers and first responders do repetitive drills, so that we can kind of desensitize that thinking. But generally, our brain it's that amygdala that responds, and it gets to decide what is traumatic to us. When that amygdala fires, it takes over the whole part of the brain. It takes over the rational thinking portion of the brain, and it gets to decide how we're best going to get out of that traumatic scenario. So our rational thinking shuts down, and our memory process shuts down, and the only thing working is that amygdala to keep us alive. So when that hippocampus shuts down, our brain goes into survival mode, and it's not making those memories as it should. It's essentially like taking a screenshot of the situation, dropping it on the floor, and it shatters into puzzle pieces. Some of the pieces are flipped over, they're not in any sort of logical order, and it's going to take a while to put those pieces back in some sort of order so that we can really see the picture of what is going on. It can take several sleep-wake cycles before the brain starts to process this again. This is why a lot of departments are waiting like 3 sleep cycles before they do a formal interview for officers involved in a officer-involved shooting. This is why a lot of departments are waiting 3 days before they do formal interviews on victims of sexual assault. It gives their brain that time to process, so they're not getting those fragmented stories that they're trying to piece together. They get a clearer, better picture as the victim is able to put those back together. So what happens to our bodies? We talked about what happens to our brain, what happens to our bodies. So as I said, when that amygdala fires, everything else shuts down. So we don't get to decide how we respond to those traumas. We've all heard of fight and flight, but there's also the third option, freeze, and it's a very real response to trauma. Victims describe it as like being awake during surgery. They're awake and know what's going on, but they physically cannot move. It is a very real phenomenon. It's just how their body perceived the best option for them to survive that. So some of us will fight, some of us will flee, and some of us will just freeze. So keep that in mind as we go through this. As Chief Baldwin mentioned, strangulation is now a felony in the state of Utah as of last year. Before then, it was prosecuted mostly as a simple assault, which is a Class B misdemeanor. This is our strangulation statute here in the state of Utah. It's a little bit looser worded than some across the nation, which is great. Ours says that any unlawful force or violence that is likely to produce loss of consciousness, which means we don't have to get to that loss of consciousness point to prove that a strangulation happened. We can still prosecute those on the felony level. Our PED statute, as Chief Baldwin kind of mentioned, also includes a positional asphyxia. So if their chest was compressed to the point where they couldn't take that natural breath, that also counts. I think there's still legislators pushing to get that into the adult statute, but it's not quite there yet. It will be prosecuted as a third-degree felony at a minimum. If we can prove gross bodily injury or long-term disability, we can get that to that second-degree level. These cases take a multidisciplinary response, which is why we're here. So we've been doing training with law enforcement. You guys are obviously part of the medical piece. We've been working with the University of Utah trying to get their response up and going. They are on board, their physicians and residents are on board with seeing these types of patients and responding appropriately and doing the imaging recommendations that are recommended by the Strangulation Prevention Institute, and we'll go over that in a little bit. Prosecution, they've been working on this for the last year, but we're finding as I consult on these cases for their domestic violence cases, and we're often very much behind the 8 ball on these. Law enforcement will go out, take 4 or 5 pictures. They're in terrible lighting with their iPhones. We maybe have a witness statement, and we maybe have a checklist that describes symptoms, but those don't go into evidence unless the victim is willing to testify, which, as we know, it's usually a domestic violence situation. They don't want to testify against their abuser. Sometimes they're still with their abuser. They don't want any part of the prosecution process. So it's very difficult for me to look at these minimal photos, minimal records, and be able to prove that there was a strangulation event that happened. So this is part of our big response why we're getting everybody on board. We would love you guys to be very descriptive in your reports, because if we don't get her report in, we can get anything medical. So if that victim doesn't make it to seeing me, a forensics nurse, which is what we're going towards, your medical reports are the only thing that is going to be able to be submitted into court. So be very descriptive when you go on these cases, especially if you're seeing any evidence of this. It's very helpful to be very wordy with your response. And then advocacy is the fourth option, and we're trying to get them involved as well. We have Salt Lake City advocates on board, but they're a agency based, so they're not a confidential resource. So they can also be subpoenaed into court, which isn't very conducive to some of these victim situations. So there's a lot of kind of moving pieces that we're trying to get in order, but hopefully it will come together smoothly. We'll talk a little bit about the anatomy of strangulation and why this is such an issue. Strangulation is defined as an external compression of the neck until either blood flow or airflow is restricted. This results in asphyxia or oxygen deprivation to the brain. The key word there is external. It is very different than what most people refer to as choking, which we'll talk about in a little bit. So the structures that are affected by strangulation are the trachea, which is obviously the rigid structure right down the middle, carotid arteries, one on each side, and the I just lost my train of thought. The jugular veins, also on each side. So carotid arteries take obviously good blood to the brain. Jugular vein dumps bad blood out of the brain. And then the hyoid bone, which isn't actually bone, it's more cartilage, is that piece right at the top of the trachea there. We also see injury to that. You guys are familiar with this. Arteries take blood to the rest of the body. The veins dump blood back to the heart. So again, the carotid arteries and then the jugular veins, and then that's just how the capillary system works. So I alluded to this a little bit. So strangulation is that external compression to the neck. Most people refer to it as being choked out or he choked me, when in actuality, choking is not an external compression. So I found this article the week we came back from the training in San Diego. The man accused of choking his father on holiday, which in medical terms that means he stuffed a sandwich down his father's throat, which we all know is not the case, but even our media is using these incorrect terms. Choking is an internal obstruction and is usually accidental, where strangulation is an external compression and is usually intentional. When you're doing these reports, please put whatever your victims tell you in quotes. If she says he choked me, that's great, put that in quotes. But be very diligent when you're writing what happened, that he strangled her. It very much helps us understand what actually happened, and the juries understand what happened. Examples of applied pressure. I forgot my toy, hold on. So these are real life scenarios. So the trigger pull of a handgun is about 4 to 6 pounds of pressure. Opening of a soda can is about 20 pounds of pressure. And then one hand on bathroom scale, if it was right here and I put my arm down on it, I could easily get 40 to 55 pounds of pressure without exerting any extra force onto it. So this is a little kind of test your strength here, just to show you how little force it takes. You can see how strong you can pull it, start resets it, but what I want you to see is how little force it actually takes to get to about 10 pounds of pressure. And it just kind of really brings home why how little force this actually takes. So we talk about how much force it takes to cause injury to these structures. It is not a lot. Jugular vein compression takes about 4 to 5 pounds of pressure, which is about the same as a trigger pull on a gun. To completely occlude the carotid arteries takes about 11 pounds of pressure, so half of what it takes to open a soda can. To completely occlude the trachea takes about 33 to 34 pounds of pressure. Our tracheas are about the size of our pinkies. We know this from our intubation, right? So think about how little force it takes and how little you have to go to completely occlude that trachea. We're not talking a lot of force to cause some real problems. Those are your signs and symptoms that you'll get with each of the mechanisms, and we'll talk a little bit more about those in detail. When we talk about damage to the larynx, you'll see bruising and bleeding at about 22 pounds of pressure, so about the same as a soda can. Again, occlusion at about 33, 34 pounds, and then that the fracture of the hyoid bone takes about 35 to 46 pounds of pressure. Most of those are diagnosed on autopsy, but if you see your patients present with that subcutaneous emphysema, start thinking about the laryngeal fracture and that hyoid fracture, and that was a fairly significant force that caused that. You guys know this asphyxia is defined as oxygen deprivation to the brain. It should always be considered a life-threatening event. Signs of this include petechiae, altered mental status, loss of consciousness, incontinence. If you're seeing incontinence in your victims, this is a sign that something very significant happened, and we should be very concerned. Any visual losses or disturbances, think stroke-like symptoms, weakness of the body, one side or the other. Bilateral carotid artery compression lead to unconsciousness in about 6 to 10 seconds. The average is about 8. I'll show you what that looks like here shortly. 15 seconds arterial compression, you will start seeing incontinence of the bladder. At 30 seconds, you'll start to see incontinence of the bowels. And again, that is a sign that there was a significant event there. Most of these numbers come from this Rosen study in 1942 out of Red Wing, Minnesota. It was the height of World War II, and they noticed that their bomber jets, their pilots, were losing consciousness when they pulled out of their bombing dives. So they wanted to know why their pilots were passing out. So they invented this, essentially a blood pressure cuff to go around their neck, and they would choke each other out. But they realized that it was hard to study when they were unconsciousness, wetting themselves on the floor. So they went looking for a captive audience, and they found, they thought, well, let's go to the prisons and see if anybody wants to contribute to the war effort. They had many different volunteers who offered to be choked out, and they kind of watched their body response to them losing consciousness. They also decided that this was probably a great way to cure schizophrenia. And for those of you that bring me psych patients to the U, know that this has not happened. We have plenty of schizophrenia here. Meth is also not a cure for schizophrenia, I'm learning. This is what they found. So at 6 to 8 seconds, they were losing consciousness. At 14 seconds, they started to see seizure-like activity, which I'll show you what that looks like. 15 seconds was the loss of bladder control, 30 seconds for loss of bowel. And then these last few minutes, or last few numbers, are from studies of people who video recorded themselves committing suicide via hanging. So we saw that the soonest somebody died or the respiration stopped occurring was at 62 seconds, and then up to 152 seconds. So a minute to 2.5 minutes is all it takes to die from strangulation. This is a video that very much illustrates what this looks like. If you search choking game on YouTube, there's thousands of these videos, which should make you feel warm and fuzzy about who's taking over our country.
This is the fastest way to knock somebody out.
Notice how short it takes him to lose consciousness.
You'll
see a little bit of seizure-like activity, and then pay attention to what he says when he wakes up.
Bicep, hand behind his head, pull up, he's done.
Here's your posturing.
Michael. What? Oh, Michael. What? Are you okay? Where am I, Michael? Oh my God, where am I? Oh my God, I can feel like I had a dream. Oh my God. I had a dream about something. Oh my God.
So if you counted that out, it was about 8 seconds before he lost consciousness. And then you saw that rigid seizure-like posturing, right? Did you hear what he said when he woke up? Where am I? He was a willing participant going into this, knew exactly what was going to happen, and he had no idea what happened. At the very end of that, he also says, I had a weird dream. So in that short of time, it put him in that level of consciousness that he couldn't remember what happened. He had that anoxic injury, and he had some sort of dream-like state. And there's also a bunch of videos of MMA fighters choking people out, and you can watch like the vital signs. So it throws them into a bradycardia, tachycardia, the bradycardia, and then they pass out. It's very interesting to see the responses on that. So we talk about how strangulation affects oxygenation. It's one of three ways. Compression of the jugular veins. This is essentially like kinking a hose. We're decreasing the amount of output coming from the brain. We're not letting that pressure out of the brain, so it's going to continue to build until it ruptures. It's considered stagnant hypoxia, so we're decreasing the amount of blood coming out of the brain, which decreases the amount of blood allowed into the brain. So you're not getting that nice, fresh refill of blood. And again, it only takes about 4 to 5 pounds of pressure to occur. It will not cause the victim to report any symptoms about breathing. We're not affecting their airway here. They'll report feeling lightheaded and dizzy prior to losing consciousness. And this is also where you're going to see your petechiae, which I'll show you what that looks like, because those capillaries continue to fill until they rupture. Compression of the carotid arteries. This is where you're going to see your rapid loss of consciousness and your rapid causes of death. Carotid arteries, one on each side. This stops, I need to change this slide, 80% of oxygen to the brain immediately. 80% of the brain is supplied by the carotid arteries. 20% is from the vertebral in the back. So if you get those headlock with the, I think it's the rear naked choke, am I getting that right? That hand across the back cuts off the vertebral arteries as well, and that's when you're going to get 100% of the blood supply to the brain gone. This is why we're taught never to check the pulse on both sides of the neck at once. Our brain likes to be perfused. It's weird. Again, this only takes about 11 pounds of pressure. They, again, will not report anything about not being able to breathe. We're not affecting their airways here. They'll, again, report feeling that they'll feel dizzy and lightheaded prior to passing out. Did somebody just surprise themselves with how much they could squeeze? We'll get who was the strong man at the end of this. Compression of the trachea. This is obviously where you're going to cut off air supply to the lungs. However, it is usually minor, if any, role in causing death. Our bodies have that reserve supply of oxygen in our bloodstream, so as long as the bloodstream is pumping. So if you just get that arm bar across the throat there, and you're not involving any of the blood vessels, you can still circulate that bloodstream, the oxygen in the bloodstream for quite a while, like 30 seconds. I guess not quite a while. 30 seconds to a minute. Oxygen remains in the lungs and blood being circulated to the brain, and you'll see signs of oxygen deprivation in about a minute. This is where your victim will state, I couldn't breathe. So turn this around. If your victim's saying, I had a hard time breathing, I was having difficulty swallowing, I'm having pain in my throat right now, you know that that was a fairly significant force that caused that. So at least 30 pounds of pressure on that throat. And if it was a hand grab, you're also affecting the blood vessels with that trachea. Again, requires approximately 33 pounds of pressure. When we talk about the mechanisms that can cause death, cardiac arrhythmias, there's the vagus nerve that also runs by those blood vessels. There's different studies on whether or not this will actually cause death. It's essentially somebody having that vagal response. Is there anybody in this room that has been around long enough to do carotid massages? You, sir. What was the carotid massages treatment for? Yes. So when you get those super fast heart rates, the idea was if you massage that carotid sinus, you would stimulate that vagal response, causing bradycardia and returning to that normal heart rate. Did you ever have it work? And it didn't work. Yeah. Yeah. And we don't do it anymore because it didn't really work that well. And you have a better chance of dislodging some clots in those carotid arteries than you do of actually stimulating that vagal sinus. So we don't do it anymore. So because it didn't work very well, the literature is kind of out on whether or not that actually is going to cause death. Obstruction of the carotid arteries, again, this is your rapid loss of, or rapid causes of death because you're restricting that important blood flow to the brain. This is also where you're going to see your carotid dissection. So Chief Baldwin mentioned that compression of those arteries against that bony structure causes tearing in that lining, causing those carotid dissections. Our body sends clotting factors to fix those, which is all great and wonderful until 8 days later that clot busts loose, goes north, and our patients stroke out. I need to find the statistic again, but there was a statistic in one of my lectures that I attended that stroke-like symptoms in anyone under 45 years of age, the greatest cause of that is a strangulation episode. So if you're seeing stroke-like symptoms in your patients that are younger, start asking some questions on whether or not they've ever had a compression to their throat. Obstruction of the jugular veins, again, this is that stagnant hypoxia. It will take a while to kill somebody via this method. It'll take probably a minute before you start seeing those signs of anoxia, and then even longer to create that hypoxia level enough to cause death. And again, asphyxia, we know this, oxygen is good for the brain. So signs of strangulation. This is where I want you guys to be very detailed in your report writing. If you start seeing any of these signs, please document them. I know you guys aren't taking pictures on scene, but if PD is there, please encourage them to take pictures. Because, again, if we don't have that victim and they don't make it to me, your guys is the only record that they are going to see. So petechiae, I'll show you what that looks like. Places to look are the neck, the wells of the eyes or the eyeballs, the roof of the mouth. We also see in the brain. I know you guys aren't going to see that, but on autopsy they'll see it. And then in the scalp or hairline, conjunctival hemorrhages. You guys see this also with blunt force trauma, car accidents, stuff like that, that those vessels will rupture in the eyes. Bruising behind and around the ears. We'll talk about that. And then red marks and scratches to the neck and chest. These are usually self-inflicted as the victim tries to pry away whatever on their neck. Abrasions can choose into the chin. They will often tuck their chin, and you'll get that abrasion to that underside of the chin. This is what petechiae looks like. It's kind of a red dotted, looks like a rash, but is not a rash. Again, the roof of the mouth is a great place to look for petechiae. Any of those smooth mucous membrane surfaces or that thin skin. This patient, the mouth is a sex assault patient of mine. She was held hostage and assaulted on and off for 9 hours and repeatedly strangled through her assault. She presented to the emergency department about an hour and a half after she escaped from that, and this is where I met up with her. But she has that beautiful petechiae in the roof of her mouth. On the petechiae, you will see the petechiae at the point of constriction and above. So think away from the heart when you're looking at this. You may also see it on your patient's chest. If you see that as well as above the point of constriction, so it essentially will look like above and below, ask if the perpetrator was straddling, like sitting on top of their chest. It will cause the restriction of that vena cava, which also will create that same phenomenon. Petechiae, again, in the wells of the eyes and the eyelids. It's present in only about 22% of the cases because you have to have that happy medium where you're cutting off blood flow out of the brain, but you're still having that blood flow into the brain. And it takes about 20 to 30 seconds of bilateral venous occlusion before you're going to get these petechiae. You can also get them from other causes: infection, allergic reaction, direct pressure. Sometimes you'll see them as on an arm from a blood pressure cuff. Generally, if they're from infection or allergic reaction, those are going to be more generalized than localized. So if you're seeing them locally around the neck, it's most likely from a compression. Dr. Yes. It's hard to say. I think the ones in the eyes are going to dissipate quicker, and it's however that big that hemorrhage is going to take longer to reabsorb. So like those conjunctival hemorrhages, they can stay in the eyes for days. Or these little petechiae, if those micro little vessels, I think that most of them will be gone within a day or so. Some of the petechiae in the skin, however, you'll see that for a couple days. Dr. Dean Hawley is a forensic pathologist in San Diego. He's done thousands of autopsies, and he says petechiae in strangulation is never going to just occur on the skin. If you're seeing it on the skin, it is also in the patient's brain. And our brain does not repair itself like the rest of our body does. So those hemorrhages will be with that patient throughout their life, and then obviously diagnosed on autopsy. Yeah? I think up until a point. So it's going to kind of gain pigmentation and then it will start to dissipate. It's hard to say because I haven't seen a whole lot and I don't get to see them like after to see how long we've been trying to do follow-up exams, but I think it will kind of increase for a couple hours and then it will start to dissipate a little bit. But it's hard to say depending on, again, how big those vessels are. It's going to take how long it will dissipate. These conjunctival hemorrhages, I'm sure you guys have all seen this, the rupture of those bigger blood vessels in the eyes. The last one I saw this, my patient she was a dialysis patient of ours, and she had puked on and off for like 2 days. And she came in, her whole eye, the conjunctival was just red. And I said, what happened? Thinking that she got hit in the face. And she said it was just from vomiting, and it would just totally occluded any white in her eye. And it was there probably for the next 4 days, 4 or 5 days. Bruising behind the ears. So I come from an EMAS background like you guys. So when I heard bruising behind the ears, I'm thinking, these patients don't have the basilar skull fractures. Why are we seeing bruising behind their ears? I couldn't quite pick out the physiological reason behind that. So it's either from blunt force trauma to the head, so a direct blow, or those patients are trying to twist out of whatever's around their neck, and they'll tear that sternocleidomastoid muscle off that mastoid process, causing bruising. So if you see that, please have law enforcement take pictures of that. And again, if you're seeing that, also ask about your head trauma. But we know that's mostly a very ominous sign. Again, scratches are usually self-inflicted as they try to pry whatever is off their neck. You'll also see it on the chest and face of the suspect. Ligatures. So you'll see this, again, the petechiae at the point of constriction and above. This is a belt around the neck. Finger sparing and fingerprint bruising. So you can kind of see where the fingers just line up on this neck. The blood will pool in between the fingers rather than the redness caused from the direct pressure, if that makes sense. So you can kind of see it'll be like a white outline of the hand, and then the red is in between the fingers. Fingerprint bruising are pretty self-explanatory. You don't have to label these if you don't want to, but please just be very descriptive in describing them. So round bruising, whatever you want to call it. It's very helpful to understand that those are present. Erythema or redness. This victim was repeatedly strangled with 2 hands. You can see those white hands around her neck with the red finger sparing in between. Oops. Patterned injuries. Again, I know you guys aren't taking pictures, but if law enforcement is on scene, please have them take a picture with and without the necklace so that we can see what caused that pattern. A lot of times when they come to the ER, everything's been taking off, so I don't understand what the pattern is that's there. Misconceptions regarding strangulation is that if a strangulation event was critical or it actually happened, that we were going to see evidence of that. They're all going to look like that with that clear hand across their neck. They're going to have petechiae. They're going to lose consciousness. A lot of times they might appear intoxicated. So if you go on scene and you get there and the man that opens the door is totally calm, collected, and he says, I don't know what's wrong. She just lost her mind. She's going crazy. She's drunk. And she's appears to be intoxicated. If you don't smell alcohol, start asking some more questions. Start looking for other evidence that this may be an anoxic brain injury or a traumatic brain injury that you're looking at rather than intoxication. Again, most of this information comes from a San Diego study. They did a study in 2001 that looked back on 300 of their previous strangulation and domestic violence cases. And they wanted to see like what kind of clues were present prior to us being called out. What they found is that most cases lack physical evidence. 50% of the victims had no visible injury whatsoever. Only 15% of them had visible injury that was vivid enough to be photographed. So we're not seeing a lot of visible injuries here, but that doesn't mean that something significant didn't happen. 67% of them had no symptoms reported or documented. So they either reported no symptoms or we're not asking the right questions to get the symptoms that we need. we know that they have to minimize. So if we're not asking the right questions, they're not going to tell us. 34% of abused pregnant women report being choked. We know that being pregnant is an increased risk of being abused. So if you're on scene with your victims that are pregnant, please start asking some questions that you may not be asking otherwise. Be very persistent in making sure that these women are okay. Again, 47% of female IPV victims report being choked. That's the national study. We're at 49%, so a little bit higher. Most experts believe these numbers are actually higher because these are the ones that we know about. So I think these numbers are a lot higher, and we're just not asking the right questions. These were the symptoms that they found. They're a little bit all over the place. The big ones, if you're seeing the loss of control of the urine or the stool, memory loss, loss of consciousness, any visual changes, weakness or numbness, start being very concerned that something significant happened, and educating your patients that they need to be seen. After a victim regains consciousness, the threat to life has not subsided. Swelling in the vocal cords can be present up to days later, causing restriction of that airway. Remember, those airways are the size of the patient's pinky. It's like spraining your ankle. The first day it might not be bad. 24 hours to 48 hours in, that ankle's going to swell up 3 times its size, right? Same thing happens in our airway. So you go on scene. She signs out AMA saying, I don't want to be seen. Law enforcement just arrested her baby daddy, and he's the only one that was supposed to be there with her for the night, so she's by herself, starts having problems later on, and doesn't have the help she needs. So especially if she's going to be home alone, please start asking if there's a family member that can come stay with her, and if she will be alone, be persistent on that she needs to be seen and screened medically. Restriction of the blood flow to the brain can result in permanent damage and can be cumulative. We know that one head injury is bad, 2 head injuries is worse. We get these sports athletes that come in, had a head injury from football. We say, cold, dark, quiet environment for the next week. Take it easy till you're feeling better and you're symptom free. These victims don't get that luxury. They don't get to go home and rest in a cold, dark, quiet environment. They're probably going to be pummeled that next day for doing something. So they have had repeated head injuries. Keep that in mind when you're seeing these patients. Multiple strangulation attempts, you're going to see the neck and throat injuries, neurological, psychological disorders. Unfortunately, a lot of this presents as mental illness. Increased anxiety, depression, PTSD, difficulty sleeping, irritability, mood changes. A lot of our victims that have this mental disorders, it's from trauma throughout their life. This is how their brain has just adapted and is able to process things now. Traumatic brain injuries, post-concussion syndromes, not all of them will experience the post-concussion syndromes, but again, it's worse in patients who have had previous head injuries because they're cumulative, and we're learning that domestic violence victims have more traumatic brain injuries than NFL players. So you think about all the research that's going into football players and their brains. Aaron Hernandez, he's the one that shot and killed somebody in the nightclub a few years ago, went to prison and hung himself. They did an autopsy and found that he had chronic traumatic encephalopathy. His family is now suing the NFL for damages because they felt that that's what changed his personality. So think about these things when you're seeing these patients, that they've had repeated brain injuries. Their brains are not going to fare well. Symptoms, again, of TBIs. Again, a lot of it is mental health, anxiety, depression, PTSD, flashback nightmares, headaches, double visions, migraines, aggression. So think about your patients that have these chronic migraines and these chronic mental health symptoms. I'm willing to bet that there was trauma, at least in their childhood, if not trauma that they're experiencing now. Evidence of altered level of consciousness. You guys know what this looks like. Dizziness, stunned or disoriented, visual impairments. The big one is if they report that they were fighting in the kitchen and then woke up on the bathroom floor. That should be a big clue that something big happened there. Again, the bowel or bladder incontinence, they'll say, I was so scared I peed myself. That's probably more along the lines of an anoxic injury rather than from terror. Also ask your patients, it may be awkward to say, hey, have you urinated on yourself? Did you lose continence of your bladder, especially if it's a male-female situation? Ask them if they changed their clothes. Something simple like, are those the clothes you were wearing when you were assaulted? And then you can kind of start piecing together what has happened. Prevalence of strangulation accounts for 10% of all violent deaths in the United States. We had one 3 weeks ago. Anybody on that call? Come on, who was there? I heard it was Station 5. Station 5 here, no? Okay. That's what I keep hearing. I'm wondering which part of Salt Lake Fire responded to this call. It actually came in as a kinky sex. Who brought that up? You. Initial reports from EMS was that it was kinky sex gone bad. I don't know what was on scene, but he reports that they were choking each other out and strangling each other while having sex. Autoerotic asphyxia, which the big nice term of it is generally a solo activity. It's usually male, as Chief Baldwin mentioned, and they're usually into cross-dressing, or things that you're going to look for. Very rarely is it a couple's thing. If it's a couple's thing, it's usually one person that wants it, the other person is their mechanism, and that person is usually sober so that they know when to stop. Very, very rarely is it two people choking each other out while having sex. That doesn't work very well. So if you're hearing these things, start thinking that it's a little bit of a fishy story, and I got from the medics that were on that day that it seemed like a fishy story. So I would love to hear what was on scene, but nobody seems to have been there. So I don't know. 1 in 4 women will experience IPV in their lifetime. That's a national statistic. Again, we are higher in Utah. Go Utah. We are at 1 in 3. Of those, 10% will experience near fatal strangulation. That's an old statistic. I think it's closer to half. We saw that 47, and we're at 49%. 750% are more likely to become a homicide victim with one episode of strangulation. So it is a building process. He's getting ready to kill her. Whenever I do this lecture, I think, has anybody owned snakes, boa constrictors? Did you ever hear the story about they lie next to their prey to see if they can eat it? This is what I think about when he's essentially lying next to her to see if he can kill her. He's just preparing that time. That's what comes in my brain every time I teach this lecture. Statistics about strangulation and sexual assault. So these are statewide statistics. In Salt Lake County, we're at 13% of sexual assaults include strangulation. We're about 10 to 12% across the nation, so we're again higher with that. In Washington County, they really like it for some reason. I don't know what's going on down there, but it's getting more and more prevalent. Whether we're asking more questions or whether we're just getting more violent as a society, my theory is that there's an increased porn prevalence, which increases some of these violent episodes. So, why we're here. This pilot project, we're looking to start, I'm hoping by the beginning of the year. We are currently prepared and ready to take these types of patients at the Family Justice Center. That's where I work. I forgot to tell you guys that. I'm the forensic nursing coordinator up there, so just 3 blocks north. We have funding for approximately 160 exams over 2 years to kind of see how we do with this. So the idea is that these patients will have the same response as like a sex assault patient. So they'll be medically screened by the ER, or if they're stable, they can have the exam done at the Family Justice Center. Stable meaning symptom-free. If they're still having symptoms, I would love them to go to the emergency department, and then we can meet up there and do the exam up there. We're doing just victims of IPV only. All of what we talked about is relevant for anybody that's been choked out, strangled, choking game, MMA. It's all the same mechanism. But our pilot project is going to be for domestic violence IPV only. So if there's a dating relationship or if this happened in a dating scenario, we will see them. Like, these exams will be done at the Family Justice Center or the emergency department. Currently, I only have access into the University of Utah emergency department. I'm working on others, but some of them don't like to play nice with other people. So my next option will probably be Salt Lake Regional, to give you guys another option for those victims that don't want to go to the U. Chief Baldwin knows a little bit more about your protocols, but you guys talked about making this a Charlie Delta response, right?
Well, what we've discussed at this point is that our biggest concern is getting them to the hospital. So we're looking at still working that piece out with dispatch because it doesn't blend in anything right now that we currently have in the protocols. But it is serious enough because of the potential for the stroke that we do need to have it be a fairly serious level of response. So we haven't figured that completely out yet as far as how we're going to dispatch on it. But what we need to focus on is the needs that the patient needs to have the scan done to make sure that there aren't any tears for those arteries. What we're doing is in image trend there'll be a drop down that will be able to click on if we do think it's non-fatal strangulation, and then it will have prompts there to tell you basically the things that all the things we've just covered. It's just a reminder, look for PTPI, look now, ask about the incontinence, those types of things. But as far as coming up whether it's going to be a Charlie or Delta, we still need to work through that, and that's we're working with Dr. Youngwood to do that. So I think our goal right now for the whole system is to go live sometime after the first of the year with everything in place. But as far as right now, when we go on these types of calls, hopefully this will mean something to you now, and you'll already start thinking about that victim and what could be happening if we don't get them to the hospital. So that's where we are right now. We realize that if we recommend they go to the U and they don't want to go to the U, that's still like any other patient we've ever dealt with. We recommend them go to the U because of the pilot, because of the forensic nurse that will be there to help them through this. But if they want to go someplace else, we'll still honor that just like we would anything else.
And we're working this through with dispatch and how we get contacted too. But if they want to go someplace else, get their medical screening exam, I'm still happy to see them at the Family Justice Center when they're done. So they can still have that forensic opportunity. I just can't go meet them at the hospital and have it done in like one fell swoop like we do at the U.
And we're not suggesting that you'll transport to the Family Justice Center.
No.
We're just saying that if they do completely refuse care, which they may, due to all the other things we talked about, all those influences about why they might not go, then we'll just tell them, please follow up, and the police officers will be working with them as well. And as far as like the pay goes, we cannot guarantee that the ambulance bill or the emergency room bill will be paid, but the victim advocacy group, in most cases, will be able, at the end of the day, be able to pay for their those expenses to have that done. Yeah. But we can't guarantee that.
I feel confident if we plug them in with services at the Family Justice Center that will be taken care of. Crime Victims Reparations has agreed to pay for anything medically necessary. So if you guys are transporting, this includes medical screening exams. They have a caveat with any sort of crime victims reparations that the victim has to participate in the prosecution process. So we asked what that looks like, and essentially it's just cooperating with that initial part of the investigation. It doesn't necessarily mean they have to testify. They're not going to chase down these victims and have them reimburse them. So I feel very confident. Again, what Chief Baldwin is saying, we cannot guarantee payment will be made, but if we can plug them in with services at Family Justice Center, we'll work it out. We want these patients to be taken care of. There are resources to take care of these patients and resources to help them move forward in a healthier environment. So if nothing else, we're working on getting them referral services. I'll make sure you guys, if they refuse care, they have the information to be able to go to the Family Justice Center. They can walk in anytime, and we'll be able to take care of them. As far as things to look for, I know you guys have a drop-down box. We've created this for first responders, so law enforcement, EMS. If this helps you, I was crazy on mnemonics when I was a paramedic. So this just kind of simplifies things on what you need to look for. And then anything positive on that, we encourage that they be seen at the emergency department. If it helps you, great. If not, great. I know you guys are great at what you do. This is the protocol once they get to the emergency department that our residents and physicians are currently abiding by. So if any of those things are positive, they will be getting that CT angio of their head and neck to make sure that their vessels look okay. It also helps us look for swelling if there's potential signs of swelling, so we can clear that out as well. And then if they don't have good follow-up. The recommendation is that they stay in observation in the emergency department for 24 hours, so we can keep an eye on them. References, this is how you find me. If you have questions, concerns, I want this to be successful, so however I can help you guys, please let me know. If you have a victim and you're not sure what resources are available, if we're willing to see them, call me and I'll make it happen. I'm at the U most weekends. If I'm not there, I'm on call for the Family Justice Center, so please let me know how I can help you guys, okay? Any questions? No? Thanks for doing what you do. You guys are great. Yeah, and hopefully this will be successful.